Okay, pectoralis major, reflecting the pectoralis major to expose the pectoralis minor. And now, come, is it visible?
Yes.
Those who are in convenient position should. Yeah. From the pectoralis minor, on the surface of the pectoralis minor, you can see a nerve here. This is the medial pectoral nerve, which supply both pectoralis minor and the pectoralis major. Okay, we are going further. This is the clavicular head of the pectoralis major. We are reflecting it down towards insertion. Okay, then this is the area of the clavipectoral fascia. Here you can see three things are piercing here. A nerve entering to the pectoralis major. This nerve is called as lateral pectoral nerve. Lateral pectoral nerve. And nearby this vessel is the thoracoacromial artery. Thoracoacromial artery. This artery, okay? And the cephalic vein enters into the axillary vein after piercing the clavipectoral fascia.
Yeah, right now you have seen the dissection. Now we'll go for the little more detail about the pectoral region. As a matter of fact, it has got a skin, deeper to skin superficial fascia, deeper to superficial fascia, you have the pectoral fascia or deep fascia of the pectoral region, then layers of muscle. Okay, coming to the skin in the superficial fascia is thin skin, thin hairy skin. If you on a closer look, you can see the cleavage line or Langer's line in the trunk will be horizontal in disposition because the bundles of collagen fibers in the dermis of the skin is aligned horizontally in the trunk, mostly obliquely or transversely in the limb, and horizontally in the trunk is the way it is seen. So why you should remember about it, because when you are putting a skin incision for any surgical procedure in the trunk, whether it is thorax or abdomen, it is better to go the incision horizontally so that after healing the wound, the serrated appearance of the wound will be lesser if you put the incision along the cleavage line. Okay. So what was the other thing you will be seeing in the superficial fascia, just deeper to skin? You have the cutaneous vessels, cutaneous nerves, cutaneous lymphatics. Cutaneous nerves, see here, can you see a line here? The angle of Lewis or sternal angle. The skin up, if you draw an imaginary line across this area, along this area horizontally, area above this horizontal line supplied by the sensory nerves called as the supraclavicular nerves. The supraclavicular nerves is a branch of the cervical plexus, supply the skin in the upper part of the pectoral region and upper part of the skin over the deltoid region. Okay. Then area below that by the upper 6 intercostal nerves. Both is anterior cutaneous branches as well as the lateral cutaneous branches of the upper 6 intercostal nerves supply the skin of the pectoral region. So your pain, touch, temperature from the pectoral region is carried by the anterior as well as the lateral cutaneous branches of the upper 6 intercostal nerve. Done? Upper portion by the supraclavicular nerves, which are branches of the cervical plexus, about which we will be telling while doing the head and neck region. Done? So deeper along with the cutaneous nerves, you have the cutaneous vessels which supply in the pectoral region, which are derived from the intercostal arteries. And the superficial lymphatic skin and fascia in the upper part, this area, pectoral region. The area above the umbilicus, this is the umbilicus, the anterior surface of the anterior part of the trunk above the umbilicus is drained into a group of lymph nodes located in the armpit. Armpit is a layman's language, we call it as axilla. A group of lymph nodes located in the axilla called as axillary group of lymph nodes. Tuber is the subcutaneous lymphatics of the anterior aspect of the trunk is drained, okay, from the level of the umbilicus. Below that, it drains down to another group of lymph nodes which is located at the junction of your trunk and the thigh. It is called superficial inguinal lymph nodes. While coming to the lower limb, we will talk about it. Okay, done. One more thing you will be seeing in the superficial fascia here is a subcutaneous muscle called as platysma. Usually the muscles are located deeper to deep fascia. But there are some region in our body where the muscles are located in the superficial fascia. The best example is your muscles of facial expression, a group of muscles located around your palpebral fissure, oral fissure. These are called muscles of facial expression. These tiny muscles are located in the superficial fascia. Okay. Again, you will be see while doing the palm, you can see a small muscle is located in the palmar aspect of the hand, which is called as the palmaris brevis. Okay. Later on, you will be while doing the abdomen, you will be see another muscle here is called dartos muscle of the scrotum. So these are a group of subcutaneous muscles present in our body. Okay. So it's present in bits in human being, but in lower animals it will be a continuous sheet of muscles. This sheet of muscle is called as panniculus carnosus. Panniculus carnosus. Okay, what does the platysma do for you? Platysma is a subcutaneous muscle which arises from the fascia over the pectoralis major, sweeps upwards and medially within the superficial fascia, covers the neck, and most of the fibers will be attached along the base of your mandible. Okay, so in that case, they protect the deeper structures. That means one of the important vein in the neck region is protected by the platysma. Done? Now the deep fascia. Deep fascia is the pectoral fascia. The deep fascia on the pectoral region is called as the pectoral fascia. The deep fascia on your forearm is called antebrachial fascia. Fascia on your arm is called brachial fascia. So based on the location, it is the name changes. Done? Yeah. So let's go for the deeper aspect here. You are seeing few muscles here. One by one. So after chipping out the deep fascia, you are seeing this beautiful muscle called as pectoralis major. Pectoralis major. Okay, and another very shapeful muscle, this is the deltoid muscle. So in between the deltoid and the pectoralis major, there is a groove, intermuscular small depression, a groove-like depression is called deltopectoral groove. The deltopectoral groove contains a superficial vein called as cephalic vein. What you are seeing in the blue color is a vein in the superficial fascia of the upper limb. It's called as cephalic vein. About its formation, termination and all, I'll tell you in another video of if time permits, I will tell you later in this video itself. Okay, done. So this is the pectoralis major. So underneath the pectoralis major, there is another muscle called pectoralis minor. Where do the subclavius located? It's a tiny muscle. The subclavius is a tiny muscle extending from the first rib to the undersurface of the clavicle. Extending from the first rib to subclavius. First rib to undersurface of the clavicle. So you can imagine the size of the muscle, so tiny, a small triangular muscle. It studies the clavicle. It keeps the clavicle in position in the movement of the shoulder, acromioclavicular or sternoclavicular joint. The serratus anterior is a wider muscle, thin but thickness is less. Thin but wide muscle which wrap around the lateral chest wall and go posteriorly and inserting into the medial border of the subscapular surface of the scapula. Let's go a bit more detail. Yeah, pectoralis major takes origin partly from the clavicle, partly from the sternum and the costal cartilages attached to sternum, and also from the aponeurosis of the external oblique muscle of the abdomen. External oblique is a muscle of the anterior abdominal wall. Done? So we can divide the origin into sternal head, sternocostal head and clavicular head. Divide into sternocostal head and a clavicular head. So the clavicular head arises from the anterior surface of the clavicle, medial 2/3 of the anterior surface of the clavicle. The fiber sweeps back downwards and laterally. The fibers coming from the sternocostal origin arises from the sternal origin and the costal origin. Sternal origin arises from the lateral aspect of the anterior surface of the sternum, from the costal cartilage, from 2nd to 6th position, okay, and from the aponeurosis of the external oblique muscle of the abdomen, okay. So the sternocostal head and the aponeurotic origin of the pectoralis major lies in one layer. On top of it, we have the head arising from the clavicular head. So the clavicular head makes the anterior lamina. Underneath you have the sternocostal head, which is making a posterior lamina. Two laminas layer, anterior layer and a posterior layer. The two layers are meeting in the lower portion, so it makes like in a U shape. This is anterior layer, this is posterior layer. They are fusing here, so it make a U shape. And they go laterally and inserting into lateral lip or the bicipital groove of the pectoral humerus. Upper end of the humerus, we have a head, a round head, and two elevation, greater tubercle. This is the lesser tubercle. In between, there's a groove called as bicipital groove or intertubercular sulcus. Okay, in this region, three muscles are inserting onto the lateral lip, pectoralis major, onto the medial lip, the teres major, and in the floor, the muscle inserted is latissimus dorsi. Latissimus dorsi. So, fancifully, they call it as the lady between two majors. The majors are the pectoralis major on the lateral lip, teres major on the medial lip, on the floor of the bicipital groove, latissimus dorsi. See here, you can see the clavicular head making an anterior layer or anterior lamina. The posterior lamina is made by the sweeping fibers of the sternocostal as well as from the aponeurosis external oblique. Here this twist happens. Twist such a way that the fibers coming from the aponeurosis of the abdomen go and inserting the highest position in the bicipital groove. That means there happens some twisting. The lower fibers will be attached uppermost and the uppermost fibers will attach to the lowermost part of the bicipital groove in the case of posterior lamina. Done? So, nerve supply. Both pectoralis major and pectoralis minor are supplied by medial as well as the lateral pectoral nerve. We have seen in the dissection while showing the structures piercing the clavipectoral fascia, I have shown you a muscle, a nerve, tiny nerve entering into the pectoralis major. That nerve is the lateral pectoral nerve. It supplies both pectoralis major as well as the pectoralis minor. After reflecting the pectoralis major, I have shown you the pectoralis minor muscle. And there I have shown you a nerve piercing the pectoralis minor and enter into the undersurface of the pectoralis major muscle. If you got any, you need a clarification, go back and see that dissection once again. So the one which is piercing the pectoralis minor is called as the medial pectoral nerve. Okay, so both these nerves supply both muscles. Let's talk about the action, what this muscle do for you. As a whole, when the complete muscle, that means clavicular as well as the sternocostal head, contract together, it carry about the adduction and medial rotation of the shoulder joint. Adduction and medial rotation. But when only the clavicular head contracts, it carry the flexion of the shoulder joint. When the sternoclavicular head contracts, it take back the flexed arm to the side of the body, not further backward, no further extension. From the flexed position, it take back to the normal condition, normal level by the side of the body. No further backward extension is possible. Done? It's an axillary respiratory muscle in case of forced inspiration. Done. Pectoralis minor. So here you are seeing a muscle which takes origin from the ribs, not from the costal cartilage. This is the rib and this is the costal cartilage. Can you see a junction here? This is called costochondral junction. Costa means rib, chondra means hyoid cartilage. So this joint is called as costochondral junction. Okay, so this thing just keep in your mind, still be helpful for you while going further in thorax and all. So just this joint is called as the costochondral junction. See here, the pectoralis minor muscle takes origin from the 3rd, 4th and 5th ribs, not from the costal cartilage. Okay. It sweeps upwards and laterally and inserted into the coracoid process of the scapula, medial border and the superior surface of the coracoid process of the scapula. Coracoid process is an example for the atavistic epiphysis. Okay, let's see. Later on, I'll tell you what is atavistic epiphysis in another video. Just remember, it's an example for the atavistic epiphysis. Okay, done. Here you can see one artery is running down. This is the artery of the upper limb. What is this artery? This artery, the axillary artery. You can see here the axillary artery is divided into 3 parts by the pectoralis minor. A first part or the proximal part which is proximal to the pectoralis minor, a second part which is lying deeper to the pectoralis minor, and the third part or distal part which is distal to the pectoralis minor. Actually, the muscle is simply going towards insertion. For our convenience, when we want to talk about the branches of the artery, the relations of the artery, for our convenience, we tell that into first part or proximal part, the posterior part or second part, and the distal part or third part. Okay. So here you can see this is the axillary artery. Axillary artery is the continuation of subclavian artery. This is the first rib. Sorry, this is the first rib. This is second rib. This is the sternal angle where the manubrium sternum and the body of the sternum meets. So at this level, the second costal cartilage will be articulating. Okay, about this is the first rib, the flattest and shortest rib. This is the first rib. So from the outer border of the first rib to the lower border of a muscle called as the teres major is the extent of the axillary artery. Done? Now you can see along the upper border of the pectoralis minor, you can see one artery is running down. Okay, this one, which will run downwards like this. Not this one, this one. This artery is called superior thoracic artery. It's run downwards here and run between the pectoralis major and minor and the supply with both muscle and intercostal space. This artery is the superior thoracic artery, which arises from the first part of the axillary artery. This is another artery called as the thoracoacromial artery. Forget about it. We'll go to that later. Okay, and along the lower border you can see another branch here. This is called lateral thoracic artery. So along the upper border you have superior thoracic artery enters and runs. Along the lower border of the same muscle we have the lateral thoracic artery. Yeah, we talked about the origin. It arises from the ribs, third, fourth and fifth rib and go and inserting into the coracoid process, the medial border and the superior surface of the coracoid process. What it do? It helps you to protract the scapula. Scapula is attached, you can see the scapula is located on the posterior chest wall, isn't it? So it attached onto the posterior chest wall by a group of muscles. If you cut those muscles, the scapula become mobile. So when you are in a pushing action or you are just press, when you are pushing the hand across the wall or when you are trying to push something, you are actually drawing the scapula across the chest wall. You just dragging the scapula across over the chest wall. This action is called as protraction. Dragging the scapula forward over the chest wall is called protraction. From this protracted condition, if you take it back to the normal position or further, is called retraction. When you are shrugging, you are elevating the scapula and taking the normal position is called the depression. So movements are the protraction, retraction, elevation, depression and rotation. A forward rotation and backward rotation. Okay. So your pectoralis minor along with the serratus anterior muscle helps in the protraction of the scapula as in the pushing movement. It also helps the same muscle in depression of the scapula from the shrugged position. You are taking the scapula down. That is called depression. Depression can happen with the gravity, with the weight of the scapula and upper limb. It may come down to the normal position by gravity, or you can do it in muscular activity, with a deliberate muscular activity by pectoralis minor and serratus anterior together. So protraction and depression of the scapula. Done? Subclavius is a small muscle which takes origin from the superior surface of the first rib near its costal cartilage, go upwards and laterally and inserting onto the groove on the undersurface of the clavicle. This groove is called subclavian groove. So takes origin from the first rib and inserting onto the undersurface of the clavicle on the subclavian groove. It's a tiny muscle which helps to stabilize the clavicle. Why the clavicle should move? Okay, when you are abducting your arm from the side of the body to the upper, this movement is called overhead abduction. It's a 180-degree movement. In this 180-degree movement, 120 degrees happening in the shoulder joint. The remaining 60 degrees happening in this joint. Can you see this? This is the acromion process. So what I am touching now is the acromion process of the scapula. This is the clavicle. So this joint is called as it's called like acromioclavicular joint. Acromioclavicular joint. Okay, it's a plain synovial joint called as acromioclavicular joint. Another joint here you can see from the medial end of the clavicle and the manubrium sternum, which is called as sternoclavicular joint. Acromioclavicular joint and the sternoclavicular joint. Okay, so at these two joints, the clavicle has got a minor movements. It can rotate forward or rotate backward. So this in the movement of the shoulder joint and the movements of these two joints, the clavicle is made stabilized by the pull of this muscle called subclavius. Done? It is supplied by a nerve called nerve to subclavius, which arises from the upper trunk of the brachial plexus, from the upper trunk. A nerve called as the nerve to subclavius, while brachial plexus, we will talk about it. Okay, what is clavipectoral fascia? Underneath the clavicular head of the pectoralis major muscle, there is a thick sheet of fascia. You can see while doing dissection, you can see a whitish or creamy colored fascia called as clavipectoral fascia. Clavipectoral fascia. Okay, so that is pierced by three structures. We'll talk about later. So here what is the attachment of the clavipectoral fascia? Medially it attaches to the costoclavicular ligament and also simply blends with the anterior intercostal membrane of the first two intercostal space. Don't get panic. Costoclavicular ligament. This is the costa means rib. The ligament between the first rib and the clavicle. This is called costoclavicular ligament. One of the important ligament through which the weight transmission from the upper limb to the axial skeleton is happening through the costoclavicular ligament. When you are carrying a bucket full of water, the weight of the bucket is transferred from the hand to your forearm, to the radius, then to the humerus, then to the scapula, then to the clavicle, to the acromioclavicular or corococlavicular ligament, and then it is transferred to the axial skeleton through the costoclavicular ligament. Okay, so your clavipectoral fascia is blending with the costoclavicular ligament and also to the anterior intercostal membrane. That is nothing but the fleshy nature of the intercostal muscles become fibrous, replaced by an aponeurotic membrane-like structure, which is called as the anterior intercostal membrane. Just remember, it is the membranous part of the external intercostal muscle. Okay, medially blends to these structures. Laterally, it goes and attaches to the corococlavicular ligament, a ligament, one of the strong ligament between the coracoid process and the clavicle, which is called as the corococlavicular ligament. Okay, and partly to the coracoid process. So this is the upper portion done, and while in the below the clavicle, it splits to encloses the subclavius within it. It gives an envelope for the subclavius, and the two lips of the envelope will be attached to the lip of the subclavian groove, which is nothing but the groove on the undersurface of the clavicle. Okay. Then, this diagram you can see here. This is the pectoralis major. This is the clavicle. This is your clavipectoral fascia. Go upward and split to enclose this muscle called as the subclavius and attaches to the lip of the subclavian groove. Clear? Then descend downwards as a single layer. As it sees the pectoralis minor, it feels like I should cover that too. So it splits again to enclose the pectoralis minor. Below the lower border of the pectoralis minor, it again become a single layer, descend downwards, and it reaches the axilla, where it continues with the axillary fascia. The deep fascia of the axilla or armpit is called as axillary fascia. Okay, when you're abducting your arm to 90 degree, just raise your arm up to 90 degree, you can see the armpit take a hollow shape, isn't it? It's like a concavity. So this concavity is maintained by the pull of the clavipectoral fascia. The pull of the clavipectoral fascia over the axillary fascia causes the dome shape concavity of the armpit or axilla. Okay, the same thing we told about it. So what are the structures piercing the clavipectoral fascia? This is your first dissection you did in your life. You just reflect the deep fascia, then you have exposed the pectoralis major muscle. You reflected the clavicular head of the pectoralis major. They have just cut the reflected and removed the clavicular head of the pectoralis pectoralis major muscle. Then you are seeing this creamy white area is the clavipectoral fascia. Now you see what all things are emerging out. You can see one vein is going deep and piercing the clavipectoral fascia and go deep. That vein is the cephalic vein. Cephalic vein is a superficial vein of the upper limb which pierces the clavipectoral fascia, make a 90-degree bend and opens into the axillary vein. Okay. Then you can see one artery here which immediately divides into 4 branches. This artery is a branch of axillary artery. The name of this branch is thoracoacromial artery. Thoracoacromial artery. Okay. Then you are seeing a nerve coming here which supplying the pectoralis major here. This is the lateral pectoral nerve. Don't get confused with nerve. These nerves are different. I'll tell you its name later. This nerve which you are seeing in the clavipectoral fascia, this nerve is called as the lateral pectoral nerve. Okay, these are the supraclavicular nerve. I told you the skin in the upper part of the chest region is supplied by supraclavicular nerve. Okay, these are supraclavicular nerve which are coming from the cervical plexus. So one more thing piercing this area is the lymphatics, lymph channels from the breast and also from the here there's a group of lymph node called infraclavicular group of lymph nodes. The afferent from the infraclavicular lymph nodes go deeper and opens into another group of lymph node which lie deeper to the clavipectoral fascia. That group of lymph node is called apical group of lymph nodes. They belong to axillary group of lymph node. Am I making you confused? Just remember here there is a group of lymph node called as infraclavicular group of lymph node. The afferent from it pierce the clavipectoral fascia to go deeper where it enters into the apical part of the apical group of axillary group of lymph nodes. So 4 things are piercing. 3 things are visible for you. That is the lacito. What is this lacito? Lateral pectoral nerve, cephalic vein and the thoracoacromial artery. Done? So serratus anterior muscle. Serratus anterior muscle is a thin but wide sheet of muscle which covers the lateral part of the chest wall over the intercostal muscles, go deeper to the costal surface of the scapula and it get inserting along the medial border of the scapula along its subscapular fossa. I'll tell you how it happens. So here you can see this muscle takes origin from the upper 8 ribs. So the portion which coming from each rib is called one digitation. So it takes origin by 8 digitation from its external surface as well as from the upper border. The 8 digitation go posteriorly covering the lateral chest wall. Okay, and it reaches the subscapular, the fossa of the scapula, reaches its medial border and get inserted over them. Over this muscle, you can see a long nerve running. In your axillary dissection, you can see over the serratus anterior muscle, there is a fascia covering the serratus anterior. Within this fascia, you can see a nerve running. That nerve is called as long thoracic nerve or nerve of Bell. Yeah, it all go all away, all this way and inserting along the medial border of the subscapular fossa of the scapula, serratus anterior. Okay. So what is do is the main action is the protraction, the dragging the scapula forward. So here just imagine this is the scapula. This is the inferior angle of the scapula. This is the clinoid cavity. Okay, this is the lateral aspect. This is the inferior angle. What is rotation? This inferior angle of the scapula is rotated laterally. It is called forward rotation. Laterally so that glenoid cavity is shown upward. This is happening during the overhead abduction. When you are raising your arm above 90 degree, that is called as overhead abduction. Overhead abduction. What is happening during the overhead abduction? So this is the glenoid cavity. This is the inferior angle. So from the lateral aspect, the glenoid cavity is exactly directed upward now. So this rotation is called as forward rotation or lateral rotation of the scapula. This is done by the serratus anterior. Okay. Along with so I told you there is the nerve supply for the serratus anterior through a long nerve called as the nerve of Bell or long thoracic nerve. This may happen either due to any bullet injury or a mistake happening during the surgery of the chest wall or carrying the heavy boulders on the shoulder. Okay, so when injury to the long thoracic nerve happens, the paralysis of the serratus anterior will be the result. So when the patient asks the patient to press or push against the resistance against the wall, when he tries to do, you can see here in the affected side, when he tries to push against the resistance, the medial border of the scapula become unduly prominent. This condition is called as winging of scapula. Winging of scapula. See, this is the normal side, no issues. But here you can see it become unduly prominent because this side it is the serratus anterior is got damaged. Done? That's all for the time being. Thank you so much.